you start. Okay, good evening, everybody. And we are going to be talking, well, okay, let me rephrase that. Dr. Chasi is going to be talking to us about abdominal x-rays. Dr. Chasi and I work at the University Hospital North Durham. He's one of our consultant radiologists. And one of the things I was told as a junior doctor, and I tell all my juniors, is that in radiology, once you become a consultant, you need a named person, your go-to person, and that you can discuss radiology with. Despite the fact that we all sometimes think we know how to do radiology, we need to talk to the expert. And with Dr. Chasi, I go to his room in a queue, people waiting to go in and talk to him, because he's an excellent radiologist, and you know, if it tells you that this is where this place is, you know that's really where it is when you walk. And I think that's a habit you should develop, and it's going to be a wonderful privilege to hear Dr. Chasi talk to all of us. Dr. Chasi is, I think, of all the people who've been talking to us, we've had only one person who's not an old Ibadan person. That's the person who spoke to you. Oh, the person who did all the radiology, the urologist, who the urology radiologist. Dr. Chasi is also not an Ibadan person. And Dr. Chasi went to university in Zimbabwe and has been with us in Durham. Well, I met him in Durham. Okay, Ishmael, the floor is yours.
Yes. Thank you. Okay. Right. Can you guys all see my screen?
Yep.
Okay. So this afternoon I'm going to talk about a few cases. The theme being the acute abdomen. In particular, I've decided to talk about the role of the abdominal X-ray. Now, this is an interesting examination, which is probably the most.
Sorry, Ishmael, sorry to
yes.
interrupt. Can you just make your screen, your PowerPoint all screen?
Okay, I just hang on maybe a second there.
Yeah, that one.
Okay, are you good now? Okay, are we good?
Yes, sorry.
Okay. So the imaging modalities that we tend to utilize in patients with acute abdomen, and I think these tend to be available in most hospitals, and I presume also obviously in Nigeria as well, is plain films, ultrasound, contrast swallows, Meals enemas, CT scans and MRI scans. But certainly the theme of the talk this afternoon is to focus on the role of the abdominal X-ray, in particular the situations where it's useful and situations where it doesn't add much value to the management of the patients. Now, I'm increasingly a firm believer in the fact that this is one of the most abused examinations in radiology. What I mean by that is that in a lot of cases, patients are referred for abdominal X-rays, and the information that you can get from abdominal X-rays, you need to be very clear from the outset what it is that you're after, because in some instances, what is reported or what looks like a normal X-ray can be falsely misleading, and in some instances can lead to unnecessary and potentially unsafe delays in getting to the diagnosis. So what I've done this afternoon is I've put together a range of cases demonstrating the kind of scenarios where abdominal X-rays would be useful, and also similarly the kind of scenarios where abdominal X-rays were not very useful, and also led to some delays in achieving the final diagnosis. So we'll move on to the cases. Case number one, again, I presume you can all see my cases, right?
Yes.
Yes, please.
Good, excellent. So the first case was this was a 15-year-old boy who came into hospital following a 1-week history of abdominal pain, and he was tender in the lower abdomen, and his blood results showed a mildly raised CRP and a white cell count. So I'm just going to leave the pictures there for a few seconds. In particular, can I just ask you guys to focus on the abdominal X-ray, just to the right of the screen there. The ultrasound actually, which he had done, was reported as normal, showed no obvious abnormality. So if I can just leave the abdominal X-ray there for a few seconds, and whilst you guys have a look at that. Can anybody see anything on the abdominal X-ray? Feel free to just shout out if you can do. So it was quite tender in the lower abdomen, in particular in the right iliac fossa. That was the site where the referring clinician stated that he was most tender. Can anyone see anything abnormal in the lower abdomen in particular?
It does appear there is a roughly coin-shaped radiopaque lesion. And the pelvis a little more to the right.
Okay, okay.
Yeah.
Do you have any idea what given the context of a young boy with pain, raised inflammatory markers, what this might suggest based on the plain film?
It might be a stone.
Mm-hmm.
My question is it in the vesicoureteric junction on the right side or something like that?
Yep, good.
That's a possibility in this instance.
Excellent, excellent. Anything else?
It could be a foreign body as well.
Okay, okay. Yes, certainly at the time, I think when this examination was performed, this opacity was noted. It's a bit laminated. You can see it's got concentric rings, and it's in the right hemipelvis. So the thinking then was, could this represent a calculus, vesicoureteric junction bladder? The other possibility was an appendicolith. And but initially, I think the thinking was more likely this might be a calculus in the urinary tract. So because of that, the next examination that was performed was an IVU. This was performed a day later. And any comments about the IVU?
It looks like it probably has a pelvic kidney, horseshoe-shaped kidney that's got a stone in it. And the bladder is pushed to the left side, or like that's about all I can make out of it right now.
Yeah, good. I mean, this IVU was performed roughly about 15 minutes after injection of the X-ray dye, and what you can see when you compare right and left, there is mild fullness of that right collecting system when you compare with the left side, and also as you've correctly pointed out there, that the bladder appears to be shifted over to the left side. But with respect to that opacity that we saw on the abdominal X-ray, it doesn't quite appear to be overlying the course of the right ureter. Certainly, it is not within the ureter. So like I said, this was performed a day after the X-ray, and so I think we weren't convinced at the time that this was within the urinary tract. So finally, the patient went on to have a CT scan on the right there, which anybody comfortable making any comments about the CT scan? So that CT scan was performed following intravenous contrast medium. And this is a transverse or axial section through the pelvis. You can just about make out the top of the hips on that CT scan. Any comments about the CT scan? Yeah, I mean, as if you look at the CT scan and if you compare that with the IVU, again, you can see the bladder The bladder is a structure which is over to the left side, which is shifted over, and that is displaced by an irregular mass. And at the center of that mass, you can see a little, a bright, a dense focus. And that corresponds to the opacity we're seeing on the CT scan. The other thing you can see as well is that there are some very dark areas around this opacity, which correspond to bubbles of gas, and there's a mass lesion. So the finding in this boy on CT scan was a mass to the right of the bladder, outside of the bladder, which contains a small focus of calcification or opacity with some gas bubbles around it. And also the other finding not shown in this study was there was a lot of omentum which appeared to be stuck to this area. So this was an inflammatory mass lesion. So anybody has a guess of the final diagnosis? So the diagnosis here was acute appendicitis. And the opacity we saw on the original X-ray was an appendicolith. Now, to go from the initial X-ray to the CT scan, that took 2 days. And I think this case probably shows one of the problems with abdominal X-rays, especially in younger patients presenting with abdominal pain. And essentially, there is no role in the vast majority of young patients coming with abdominal pain. And in most cases, I think we're actually quite lucky in this case that there was a positive finding on the plain film, which was the calcified opacity. In most cases, in young patients with abdominal pain, even with rip-roaring appendicitis, the X-rays is normal. And the danger is that what do you think is a normal X-ray can hide a lot of significant pathology. And therefore, this is an example of a case where there was a significant delay in diagnosis. This is what 2 days from the original presentation. You could make an argument that clinically, the clinicians should have been appreciated you know, if there was a better clinical assessment, they should have gone on the basis of symptoms. Because sometimes your radiology might be negative, but if the surgeon or the clinician has a strong suspicion that the patient does indeed have significant surgical pathology, there are clearly instances where the surgeon will elect to go ahead and either do a laparoscopy or you know, even more than that. But I think these days imaging is actually quite useful at pinpointing the diagnosis before you go to definitive surgical treatment. The point here is that you need to pick the right imaging technique. In this case, what the first exam should have been an ultrasound. Obviously, the ultrasound was reported as normal, but there is a question as to whether it was a truly normal ultrasound or did we just miss it on the ultrasound scan. Okay, so this is a case of what was an inappropriate use of abdominal X-ray in a young patient who the sequence should have been ultrasound scan first. And I think CT scan following ultrasound, that was okay. Obviously with young patients, CT scan, we do try to avoid CT scan because of the risks of ionizing radiation, but certainly where there's significant clinical concern, and there certainly is a role for performing CT scan because it is quite good at pinpointing the source of the problem in surgical patients. So that was case number one. Second case, this is a 39-year-old female who was diabetic, and she came in with vomiting over a few days and had not had any other imaging up until that point. And so this was an X-ray done in the middle of the night to try and investigate the vomiting. I think also on examination, the clinicians noted that she also had abdominal distension. So again, can anybody spot anything on this examination?
Okay, I think that to be fair to, I think it's only been, or Adequate has been answering, to be fair to him. I'll be picking on people to answer the question. Okay, can I pick on Ilesami, Dr. Ilesami?
Good afternoon, sir.
Good afternoon.
Yes, sir.
Yeah, you want to
Yes.
answer Dr. Chasi's question?
All right, sir. Yeah, on the radiograph, there seems to be an extensive ground glass appearance at the upper part of the abdomen, extending from the left hypochondriac up to across the epigastrum to the right hypochondriac region.
Okay. Good. Do you have an idea what anatomical structure this might represent? You've described it quite well in terms of where it's extending from, and that description, if someone was on the phone, they could actually have a reasonable idea based on what you've said in terms of what anatomical structure fits to that description in terms of location.
Yes, sir. I'm thinking possibly the stomach or stomach. It could be the stomach.
Good.
Yeah.
Yes, this was actually the stomach. Now, the next question for you is, do you think that is a normal stomach, or do you think it's an abnormal stomach?
I think it's an abnormal stomach. It looks quite distended. It looks quite big.
Excellent, good. And based on that history, do you have any ideas as to what might be causing a stomach? As you rightly said, it's got this mottled appearance. It is markedly distended. Any clues as to what might be causing this in a diabetic female?
Probably she has some gastroparesis affecting gastric emptying. Probably she has some gastric outlet obstruction, also possibly from pancreatic disease.
Good, excellent. Yeah, so I think certainly when she came in, that was a thinking on our minds as well. Gastroparesis was the most likely diagnostic consideration for us. And obviously, as you pointed out, gastric outlet obstruction is in the differential. The other thing that could give this appearance is a bezoar. And that's clearly very rare, but the top two things to consider in this case here would be gastroparesis or gastric outlet obstruction. You can see that the large ball is displaced inferiorly, and this is clearly stomach. And I think once you've established the fact that this is a stomach, then that's half the job done. So this lady, she went in to have a CT scan. So this is a coronal CT of the abdomen and pelvis. And I'll just take you through this. You've got the liver up here in the right upper quadrant. This patient has had intravenous contrast medium. So we use that to try and highlight the differences between normal tissue and pathological tissue. And you can see in the left upper quadrant, you've got this mottled structure here, which is distended, contains fluid as well. And this is a stomach. And the arrow is just hovering over the gastric antrum and the pylorus. And the point was there was no evidence of any mass lesion or anything. Essentially, when you're the point of the CT was to exclude gastric outlet obstruction. You could argue that an OGD might have been the test to do, but quite often in these kind of cases, it can be difficult to actually visualize what's going on in the lumen when there's so much debris and food residue. But certainly CT scan, in terms of obstruction, there was nothing in the lumen, there was nothing in the wall of the stomach, and there was nothing extrinsic. So on the basis of that, we concluded that there was no evidence of any gastric outlet obstruction, and ultimately the diagnosis in her was actually gastroparesis with no other complications. Okay. Case number 3. So case number 3 was a 30-year-old male. This was a guy who had diarrhea for 3 weeks and was recently admitted to hospital to try and investigate the diarrhea. And as part of that, he had a colonoscopy. And and then he went home after the colonoscopy, but then he was readmitted the following day with abdominal pain and tenderness. So this X-ray you're looking at now is 1 day after he's had a colonoscopy for investigation of diarrhea. Now, again, I'm just going to throw it back to you guys. Can anybody spot anything abnormal in this X-ray of the abdomen?
Dr. Bukbola?
The plain abdominal X-ray shows dilated loop of bowels and absence of gas in the pelvis. There is dilated loop of bowel, particularly the large bowel, evidenced by presence of ostral markings. And then I could not see hair in the pelvis. So I think the patient has an intestinal obstruction.
Yes, I mean, some points there you made were valid. Certainly, if you look on the right side of the abdomen, there is this distension of the cecum. So my arrow is hovering over the cecum and up towards the ascending colon to the hepatic flexure. And certainly you're right, there are haustra here. Now, this is what we call thumbprinting, where we see this prominence of the haustra. And there is some gas projected over the pelvis in a loop of, this is a bit of a sigmoid colon here. But you're right, there's no gas in the rectum. But this was actually a patient with diarrhea. And what you see in the right colon is thumbprinting, edema of the wall of the colon. The other thing you can't see is you can't see any fecal residue. Now, fecal residue in patients with diarrhea, that's what you quite commonly see, or with a colitis, is you see an absence of formed fecal residue because of the fast transit of food and fecal matter through the colon. So what you're saying here, as I said, is a patient with a colitis, which was obviously the cause of the diarrhea. It was affecting the whole of the colon, because you can see edema of the colon on the right side. And if you closely look on the sigmoid colon, that also looks a bit edematous as well. So the whole colon is inflamed. So this patient has got a pancolitis. And the reason that he then presented with, can anybody else suggest a cause of why he then represented following the colonoscopy with abdominal pain? So we know that he's got a colitis, but something else has happened on top of that to now cause him this pain with which he has been readmitted. It's probably not the most easy scan to interpret, but if you look up here in the right upper quadrant, you can see this loosened area, which is outlining a soft tissue density over here. Now, this is gas outlining the kidney. And when you see gas outlining the kidney, that is clearly abnormal, because you don't normally have gas in the retroperitoneal space. You can also see gas over here on the lateral aspect of the abdominal wall. And so the diagnosis here was a retroperitoneal gas following a colonoscopy. And the explanation has to be that there was a retroperitoneal perforation of the ascending colon. And that would make most sense based on the distribution of the gas. We know that the ascending colon is retroperitoneal, so that explains the gas distribution. So this was just a complication following a colonoscopy in a patient with a colitis. So certainly abdominal x-rays in the setting of colitis are useful in terms of tracking the progress, especially in the acute phase where patients are having diarrhea, especially if there's a concern, for example, for either toxic megacolon or bowel perforation. In this case, this was quite useful in someone who's obviously had a colonoscopy. Okay. Next case, case number 4. This was a 25-year-old young woman who had a sudden onset lower abdominal pain and vomiting and a tender lower abdomen. She had normal inflammatory markers, and this was the abdominal radiograph. Again, any volunteers, please, or can somebody be volunteered?
Okay, Dr. Awi, is that Awi?
Yes, sir.
Okay, go on for it.
Can you see anything in the lower abdomen?
Is the abdomen is gasless, sir. The pelvis, sorry, is gasless.
Agreed. Anything else?
There are two hyperdense or hyperopic lesions in the pelvis that I can see.
Very good. Just by looking at them, can you tell what they look like? Just by looking at one of them, let's focus on the one that's lower down in the pelvis. What does this look like to you?
These are the tip of the appendix.
Yes, I mean, it's not quite corresponding.
Yeah.
I know the first case we saw was appendiculitis, which was down in the right hemipelvis,
Yes.
almost this kind of area. Typically, appendiculitis, you tend to get them this kind of area here, but there is this opacity here. There's another clump of opacities as well over this area here. And I don't know if anybody else can suggest what they look like. That's actually quite critical in this case in terms of determining the final diagnosis. This was actually a case where we made the diagnosis before we did the further imaging. Anybody else tell what shape this looked like?
Dr. Deyamo, if you're not talking, please, can you switch off your microphones? Thank you. Dr. Pokmola, you switch off your microphones. Okay, Dr. Constantine, do you want to talk?
Yeah, my network has been having a problem. But if this were to be a woman, then there's possibility it's a calcified myoma, and also I can see that on the right and on the left side, the ascending colon seem to have fecal stippling, and the descending colon as well. And on the central part of the abdomen, there seems to be a dilated structure there. So I'm not sure exactly what this classification is, but I think this bowel, the large bowel, is fecal loaded, and perhaps there is a possibility of sigmoid volvulus here, but I'm not sure of what these classifications are. But in a female, it could be calcified myomas.
Okay, that's a fair suggestion. But when you look quite closely, these actually look like teeth. This one here, for example, and then if you look at this clump of opacities here, this looks like a clump of teeth. Now, given that finding, so radiologically, anybody know what diagnosis we then made?
Yeah, I would then start thinking of ovarian teratoma.
Good. Yes. So we actually made the diagnosis of an ovarian mature cystic teratoma or a dermoid, and she had come in with sudden onset lower abdominal pain. And what can happen with dermoids acutely is you can get torsion or rupture, and those are two complications which you can get, which can result in sudden onset presentation. So she did actually go on to have an ultrasound scan of her abdomen, which is an image in the top left here, which just showed a mass lesion in the pelvis, and which was displacing loops of bile from the pelvis. And then subsequent to that, she also had a CT scan performed. Now you can see on the CT scan in the center of the image there, you've got these dense opacities, and surrounding that, you've got areas of low density soft tissue. My arrow is just hovering over this area here, and this looks just like your subcutaneous fat. So you've got a mass in the pelvis containing calcifications which look like teeth. You have fat in it. As I said, it looks like your subcutaneous fat. So you're right, this is clearly a mature cystic teratoma or a dermoid which had ruptured into the peritoneal cavity. whilst normally in young patients with abdominal pain, this is actually a case where we got the correct diagnosis from the outset using abdominal X-ray, although the abdominal X-ray was not the right test to perform initially. The right test to perform in this history would have been an abdominal ultrasound and then a CT scan. There was no role for an X-ray of the abdomen in this case, but as it happens, sometimes where you have certain masses which have characteristic appearances such as dermoids, abdominal X-rays can be useful, but I wouldn't have done that as a first test. There was also actually a delay of about a day between performing the X-ray and the CT scan. I can't remember what the exact scenario there, but sometimes that's what happens when people are making a confident diagnosis. And I think that was why people ended up doing a CT scan here. Whilst we did think it was a dermoid, I think there was some doubt that was it actually the cause of the pain? Because just because you have a dermoid and pain doesn't mean that the dermoid is the cause of the pain. You can have a dermoid and appendicitis. So ultimately, the CT scan was useful in confirming that actually the dermoid had indeed ruptured. And given that, we could then make a confident diagnosis that actually that is the likely cause of the pain, and then refer to gynecologists. Case number 5 is a 25-year-old male who had had diarrhea for 3 weeks and anemia. And he had this abdominal X-ray, and which was done supine. Can anybody tell me what's going on there, please, on this abdominal X-ray? If you can just focus on the upper abdomen, forget about the lower abdomen. Anybody tell me what's going on in the upper abdomen?
Naomi.
This is probably not the most easy X-ray to interpret. I'll just talk you through this one first, and I'll see if you can take it on from the next one. So this one shows edematous transverse colon. My arrow just hovering over right now with areas of thumbprinting. In a patient with a diarrhea, also with an absence of formed fecal residue in the right colon. This again is consistent with a diffuse colitis. Obviously, in a young patient, the 2 commonest causes is going to be infection or inflammatory bowel disease. But certainly that's what the X-ray shows. The rest of the bowel gas pattern is normal. Now, the other thing I meant to mention with respect to abdominal X-rays is if you are going to do them, we need to make sure that technically adequate. And by that, I mean that the lower aspect of the X-ray, you should make sure that you've included your hernial orifices, i.e. your inguinal hernial orifices. You can see here, this has stopped quite a few centimeters above the level of the pubic symphysis. So you need to be a few centimeters below the level of pubic symphysis because, for example, if the patient has an obstructing hernia, you'll miss that on the X-ray. So this was not a technically adequate examination, but in this case, it wasn't actually crucial because this was done for diarrhea. Was this an appropriate investigation to do in a patient with diarrhea? It is if the question was, if the concern was regarding, are they developing toxic megacolon, or if there was a concern for bowel perforation. Anyway, this was the initial examination performed for this young male, and he then deteriorated a couple of days later, and again the concern was for has he perforated, and this examination was performed, which is an erect chest X-ray, and this is your exam of choice if you're querying bowel perforation, because in that case the free gas would collect below the diaphragm. So as you can see, there is no free gas, and he became quite tender in his abdomen on clinical examination, and he had more pronounced bowel distension, and his inflammatory markers were rising since the admission. So the concern now was that, is this guy developing a toxic megacolon? And when you compare this examination here with the first one, you can see now that there is more pronounced distension. So not just the edema now, in addition to the edema, you're now seeing that there's edema thumbprinting, there's no fecal residue, and there's distension of the transverse colon. So toxic megacolon is not a diagnosis you make on X-ray alone. It's a combination of X-ray and clinical features as well. And so I think the thinking in this guy, given the clinical deterioration and the X-ray findings, that he was developing toxic megacolon. He actually also had a CT scan on the same day as that abdominal X-ray. And you can see from the CT scan a few slices. These are done coronally. And you can tell that this looks a bit like what the plain film looks like, which is distension of the colon with an absence of fecal residue. And the whole of the colon is thickened edematous. And this guy has got a pancolitis. This was a young guy who had ulcerative colitis, and eventually was taken to theater and had his colon removed because of the concern for toxic megacolon. Okay. The next case is case number 6, was a 50-year-old female who was obese, right upper quadrant pain with mildly deranged LFTs. Now, she also came in the middle of the night and had an X-ray of the abdomen performed. Now, this just looking at the history alone, that would be an inappropriate use of a plain film. There is no role of CT scan in this kind of scenario. The first exam she have done in this patient would have been an ultrasound scan of the abdomen rather than a plain film. Nonetheless, the plain film did show some positive finding. So just focusing on the right upper quadrant, can anyone spot anything abnormal in this exam?
Okay, answer because I can see 2 people microphones are off. Just answer, whoever wants to answer.
Just go for it.
What's in the right upper quadrant, a fairly well circumscribed, I think oval, with the where the wall is opaque and with the hyperopacity of the wall of, I think it has a gallstone.
Yes, good. I 100% agree. But it's more than just one gallstone. There's several gallstones on there, and yeah. So despite this not being the appropriate examination, it did show multiple gallstones. But again, a bit like the derma, just because you've got gallstones in someone with pain, it doesn't mean that that is the cause of the pain, and that is a weakness of X-rays. X-rays actually pick up, not probably about 60% of gallstones. So they miss a large number of gallstones, and so a negative abdominal X-ray does not rule out gallstones. And also, just because you've got gallstones seen on an X-ray doesn't mean that that's the cause of the pain. The more appropriate exam, like I said, would be an ultrasound scan. So I've shown a different patients who've had the more appropriate exams. In the top left corner here is an ultrasound scan of the gallbladder, showing you what a patient with gallstone with cholecystitis would look like. So this is a gallbladder over here, and you can see that it's got some these small opacities in them, or these echogenic areas which correspond to gallstones. The other thing is that the gallbladder wall is quite thickened, and normally you're allowed up to about 3 millimeters, and this is more than 3 millimeters. And also there is some fluid around the gallbladder. So this patient here has got calculus cholecystitis, and in the correct clinical scenario, that would be more diagnostic of cholecystitis. As I said, the plain film would not be, because just because you've got gallstones doesn't mean you've got cholecystitis. In the middle here, the CT scan, which shows again another patient with cholecystitis. There's a gallbladder here in the right upper quadrant. You can't actually see the gallstones very clearly on this view, but there's a markedly thickened gallbladder wall, and this was also cholecystitis. And finally, the image on the extreme right hand there shows you an MRCP, which is an MRI scan done to look at the bowel ducts and the gallbladder. And you can see on this that you have some areas of filling defects in the gallbladder, with thickening of the wall. So this is also a case of cholecystitis. But the correct sequence in a patient you suspect has got cholecystitis will be to do an ultrasound scan first. Now, I'm not sure about certainly where you guys work, but certainly in my hospital, ultrasound scan is typically limited 9 to 5, Monday to Friday. So what that means is that patients coming in the middle of the night, you don't have the option of ultrasound. And some of these patients end up inappropriately getting x-rays, which is a wrong thing to do. If you don't have access to ultrasound, if someone comes in the middle of the night, if you have access to it, I would go for a CT scan, because that is far more reliable at diagnosing cholecystitis. You really can't diagnose cholecystitis with a plain film. So there is no role for x-rays in biliary tract pathology, really, of any kind, save from possibly one condition, which I'll talk about later on, okay? Next case is case number 7. This is a 17-year-old girl who came to A&E. She actually had multiple attendances to A&E, a regular attender. And on this occasion, she had abdominal pain. And this was an abdominal x-ray performed when she came in. Now, this actually is an appropriate use of an abdominal x-ray. And can anybody make any comments as to what they see in the central part of the x-ray here?
Dr. Adeyemo. Mashood Adeyemo. Okay, he's missing. Okay, Alabipopola.
Yes, sir. The plain X-ray shows on the day of spine instability, multiple vertebra with spinal stabilization with pins and screws.
Good. Anything else?
Just Ishmael, hang on. Dr. Nwafulaku, can you shut your microphone, please? Thank you. Okay, sorry, Ishmael.
Yeah, I certainly agree. As you said, this patient had spinal stabilization, and you can see that one of the rods is actually fractured. But in addition to that, I'm sure you can all make up, there's an additional metallic density opacity projected just over the right side of the spine. Now, this does not correspond to the spinal stabilization. Now, this was actually a foreign body. This is a patient with a long history of ingesting foreign body material. And on this occasion, she had swallowed a couple of batteries, and this was one of them. And so this would constitute an appropriate indication for x-rays. In other words, when you suspect that patients, there's a history of ingestion of either blunt or sharp foreign bodies, and it's actually very good, especially if it's metallic density. Obviously, if it's something that is not of metal density, the x-rays can struggle. Things like drugs, for example, recreational drugs, drug packers, that can be quite difficult to spot on plain films. But if whatever it is that has been ingested or inserted into an orifice, x-rays are very good if whatever that object is metal in consistency. So this is an appropriate use of an x-ray. The next case, number 7, is I'll just talk to this one here because I think we've seen a couple of examples of this kind of scenario before. This was a 71-year-old male who had been on recent antibiotic therapy for urinary tract infection, came in with a 2-day history of diarrhea, and he had also abdominal distension. And so he had an abdominal x-ray. In this case, you can argue that this was an inappropriate indication. There is no role for abdominal x-rays in patients with diarrhea unless you're suspecting toxic megacolon or in the setting of inflammatory bowel disease. But certainly, box standard diarrhea, there's no role for that. But in this patient here, He subsequently, 2 days later, developed severe abdominal pain. And you can see on these two examinations here, on the left, he's got a distension of his transverse colon with thumbprinting. So during his admission, certainly, it certainly looked like he also developed toxic colon. Clinically, that fit as well because he was unwell, tender, raised inflammatory markers. And also he's got distension of his small bowel. The other complication that you can detect on here is that he's got free gas in his peritoneal cavity. So if you look over here in the right upper quadrant, this is unusually lucent. And also if you look over here, you can see what is called wriggler sign. Wriggler sign is when you can see both sides of the bowel very, very clearly. That is because on the one side, there's gas in the lumen of the bowel. On the other side, there's gas in the peritoneal cavity. So it looks very, very sharp. And that is a sign that is you see in patients with pneumoperitoneum. If you're not sure that it's there, the thing to do is you do an erect chest X-ray because that is more reliable at picking up gas, which will be under the diaphragm. So this is a patient who had again toxic colon with bowel perforation and pneumoperitoneum seen on an abdominal X-ray. As I said, the exam of choice, if you're suspecting bowel perforation, is not an abdominal X-ray; it's an erect chest rather than abdominal X-ray. But certainly there can be clues on the abdominal X-ray that the patient has indeed got pneumoperitoneum. So the case number 9, this one should be fairly straightforward for you guys. This is a 69-year-old nursing home resident, abdominal distension and constipation. And this was the X-ray on admission. And can anyone hazard a guess as to the diagnosis? I need a diagnosis this time because I think this is one that is fairly a typical appearance of the diagnosis. Anyone give me the diagnosis here, please?
Sigmoid volvulus.
Yes, I mean, this is absolutely classical. Your coffee bean shape is pointing into the left iliac fossa. This is sigmoid volvulus. And some of these patients quite often have recurrent admissions, but yes, absolutely typical of sigmoid volvulus. So plain film is actually quite good for these recurrent attenders. While CT scan is definitive in terms of showing you the twist in the mesentery, it's difficult to justify doing CT every single time these patients come back into hospital. So certainly that is one scenario whereby you could, certainly make a good argument for doing plain films. And this is the same patient again, slightly different on a different day. Again, you're showing this distension of the sigmoid colon pointing down into the left iliac fossa. There's equivalent CT scan. What this doesn't show you is the actual twisting of the mesentery, but this is a classical case of sigmoid volvulus. And you can use plain films following insertion of a rectal flatus tube to track the progress and see what's happened, how the patient has responded following the decompression. Okay, so case number 10. This was a 55-year-old woman with abdominal distension and non-specific abdominal pain. In addition to that, she'd had some bloods taken by the GP, and that showed a mildly raised CA125. And so this was the abdominal X-ray which was performed when she was admitted. And again, can I have any volunteers as to what is the key finding in this examination?
I think she has pancreatitis.
Why do you say that?
There is this ground glass appearance that may suggest ascites. And
Excellent.
then with that history of CA125, that may be a pointer to exudation from a pancreatitis. So that ground glass we are seeing are basically their fluids from the exudation of pancreatitis. So my suspicion is probably she has a pancreatitis.
Good. I mean, you're partly correct in the sense that very good observation there. This is ground glass opacification in the flanks on both sides, and the flanks look to be bulging. Centrally of loops of bowel which are displaced towards the midline. So this is a patient whom on the X-ray clearly has evidence of free fluid or ascites. And having said that, it's a very non-specific appearance. So all you can tell from the X-ray is that the patient has got free fluid. There's obviously a myriad of causes in terms of free fluid, anything from cardiac, liver, vascular pathology, and neoplasms as well. But the one positive finding on here is the ascites. The bowel is not distended. The next examination, this was another patient, again, the same finding, ground gloss appearance, haziness of the abdomen. It almost looks like quite a poor quality exam, but it's because there's all this free fluid that's in the peritoneal cavity. This is the ultrasound scan performed in the image on the right. This is the, you can see where the arrow is pointing. There's a large volume of ascites. Again, the image below that, the dark area, the black area, that corresponds to ascites. Again, on the ultrasound scan, the scans wasn't really diagnostic. So we then proceeded to perform a CT scan of the abdomen and pelvis. Now, this examination here was done following oral contrast. You can see where the arrow is. You've got this dense area. What we used to do in the past was we'd give patients X-ray dye to drink, and that showed us where the bowel was. These days, we don't tend to do that. Patients just come off, they don't get given anything to drink in the acute setting. They just have the scan straight. The one advantage of using the oral contrast was that you could actually see where the bowel was very easily. In this case, you can see that these areas here where my arrow is corresponding to bowel, but there's extra soft tissue here anteriorly in the anterior aspect of the abdomen. Can anyone tell me what you think this is? This is probably not as easy to if you've not seen many CTs, but this is the omentum anatomically. So abdominal wall is here, and then just beneath that, you've got your omentum. So this is omental caking. And this patient's got extensive omental caking on the CT scan. You can see what I'm tracing with my arrows over here. So this was a patient with peritoneal and omental malignancy. In a woman, the most likely cause is going to be ovarian carcinoma. Okay, so that was the diagnosis. But the plain film in that case, all it showed was just ascites, but you couldn't really come to that conclusion based on the plain film. Okay, case number 11. So this is a 55-year-old male, diabetic with severe abdominal pain and raised lactate. So I'll talk you through this plain film because it's not as easy to pick up the findings. So in terms of technical adequacy, I mentioned that a few minutes ago. This one is barely adequate, but again, you want your inferior aspect of your X-ray to be slightly lower than that so that you can clearly see if the patient had a hernia, for example, and suspecting bowel obstruction, you need to be able to see the ischial tuberosities, but in this case, they've just trimmed them off. So the positive findings of this exam here, if you look in the right upper quadrant, you can see some branching lucencies over where the liver should be. And in addition to that, if you look here on the left flank, you can also see some linear lucencies overlying loops of bowel. Now, based on the plain film, we also had some distended loops of bowel. So based on the plain film, we thought that this patient had gas in the portal vein. The other possibility when you have branching lucencies or gas-like lucencies in the liver is gas in the bowel ducts. Now, the way to tell the difference on a plain film is that gas in the bowel ducts tends to be more centrally located, whereas gas in the portal vein tends to be more peripheral. So those gas in the portal veins, there's also this gas here, which we thought was in the bowel wall. Now, in a patient who's got abdominal pain, tenderness, raised lactate, gas in the bowel wall, and gas in the portal vein. Does anybody want to suggest what the diagnosis might be?
I'll be thinking the patient has ischemic bowel and maybe they subsequently had the bowel perforation.
What examination would you like to do next?
I an erect chest X-ray would not be out of place in this case. But at the same time, I'm wondering if this patient is stable enough to have this sort of imaging, considering the fact that they're diabetic and they've got severe abdominal pain and severe raised lactates.
Good. Yeah. Yeah, I mean, the point about the X-ray was a valid point. The additional value of the X-ray in this case would be to look for a bowel perforation, and I agree 100%. Acute mesenteric ischemia was a suspicion based on the X-ray and the clinical scenario. On the basis of X-ray alone, you couldn't actually diagnose mesenteric ischemia, but it was a scenario that was suspicious. You can sometimes have gas in the bowel wall and gas in the portal veins in patients who do not have mesenteric ischemia. So it is quite important to link the X-ray findings to the clinical history. If you try and interpret the X-ray divorced from the clinical scenario, you could end up with a misdiagnosis. But in this case, the clinical symptoms were indeed suspicious or worrying for mesenteric ischemia. So we went on to perform a CT scan. I think in these kind of cases, almost invariably, the clinicians will request a CT scan. And the CT scan, which I have up here now, there's a transverse or axial view and a coronal view. The coronal view was actually done pre-contrast, and then the axial view was done post-contrast. And you can see on the coronal view, first of all, on the far side here, there's gas in the portal vein, and there's also gas in the mesenteric veins as well. And on the axial view, we've given iodine-based contrast medium. You can see there's enhancement of the kidneys. There's aorta here in the center. There's IVC, and these are loops of small bowel. And you can see where my arrow is now. There's a thin rim of gas in the wall of the bowel. Now, the crucial diagnostic finding in terms of mesenteric ischemia is not actually the presence of gas in the wall of the bowel or even gas in the portal vein, but it is the absence of enhancement of the wall of the bowel. You see that is diagnostic of mesenteric ischemia and possibly infarction as well if it's completely non-enhancing. So this was a case where we started off with a plain film and we ended up doing a CT scan. In this kind of scenario where patients come in with abdominal pain and raised lactate, a plain film is not the examination to do. So this was an inappropriate use of an abdominal X-ray. The reason being that if the X-ray was normal, this patient was going to have a CT scan. If the X-ray was abnormal, this patient was going to have a CT scan. In other words, the abdominal X-ray did not change the management. This patient was going to have a CT scan regardless of what we found on the plain film. And I think that seems to be the theme in a lot of cases, that clinicians ask for X-rays when the result of the X-ray doesn't change the fact that the patient is going to need a CT scan anyway. If someone comes from their house to hospital at 2 o'clock in the morning and you do an X-ray of the abdomen and you wait another 5 hours because you think the X-ray is normal, you're wasting valuable time, and that can result in an increase in morbidity and potentially mortality as well. So it is important to recognize cases where if you do have access to CT scan, especially overnight or out of hours, in patients with abdominal tenderness, your surgical abdomen, you go out and do a CT scan, especially with just tenderness rather than obstruction, because you can unnecessarily delay management by doing plain films. Case number 12.
Ishmael, before you go on, just quickly going back, somebody asked, I think it was on the plain film, that where is the air in the portal vein?
Yeah, on the plain film, as I said, if I'll just go back to it now. You can see over here that the branching, it almost looks like static branching lucencies over the liver. So where my arrow is now, you can see these linear lucencies. That is the end of the portal vein. This is actually a difficult spot. You probably need to magnify your image quite a lot to be able to see that very clearly. But it's a kind of thing that is, these days we rarely see it because most of these kind of scenarios, these patients are going to get a CT scan, not a plain film. And by the time you see gas in the portal vein like that, it typically means the prognosis is quite poor. Although because we're scanning so many patients these days, it doesn't necessarily always mean it's a poor prognosis, but these areas here, where my arrow is, this is the gas in the portal veins. So the other option is gas in the biliary tree, but that tends to be more central. And this is quite peripheral. So this, on the base of that, we make a diagnosis of portal vein and not biliary gas. Okay. Okay, moving on to case number 12. This was a 25-year-old with anemia and abdominal distension and abdominal pain. And she had an X-ray of the abdomen, which was performed because of the abdominal distension. Now, in this case, the clinicians were not actually suspecting bowel obstruction. So again, this is another example of an inappropriate use of a plain film, and in a patient who was young. So moving over to the plain film, and I'll just talk through this one here. And you can see that in the left side of the abdomen, there's a large soft tissue density, which is displacing loops of bowel around it. It looks fairly solid. If you remember the patient who had the gastroparesis, that one had mottled lucencies or mottled appearance, whereas this one here is fairly solid looking. And again, that gives you a clue as to what structure this might be arising from. But again, this was an inappropriate use of an X-ray, because in a young patient with abdominal pain and distension, your X-ray would not be your first exam. Your choice would be either ultrasound scan or straight to CT, depending on whether there were other features on clinical exam or in the blood results. And now this patient went on to have a CT scan following an ultrasound scan, and this was just a big spleen. And this was a patient with a hematological condition. I think it was a myeloid leukemia. But the point being that just because you've got abdominal distension doesn't mean that you need to go on and do an abdominal X-ray. You've got to put it in the context of other symptoms, the age of the patient. In younger patients, you really should be thinking of ultrasound first and CT. If not ultrasound, if the patient is sicker, go for CT. But certainly plain films can be falsely reassuring, so that's why you tend not to do them first. The next patient is case number 13, is a 65-year-old woman who had had a previous laparotomy for perf DU, and she now presented with abdominal pain and vomiting. Now, this is X-ray performed. Now, there's clearly bowel distension on this examination, but my question to you guys is this small or large bowel? And why do you say this is, and can give a reason for your answer, okay?
I think it's a large bowel.
Why do you say large bowel?
Nostra markings.
Okay, anybody else agree or disagree with that?
I would think it is small bowel.
Mm-hmm.
First of all, from the history, she's had a previous laparotomy for perforated DU. So I'm thinking she probably has adhesive bowel obstruction, which in most cases is small bowel. So I'll think about that. I'll keep that in mind while I have a look at the X-rays. And then looking at the featureless distended loop of small bowel to the right side of the abdomen, that looks like small bowel to me. That looks like ileum. Essentially, it seems to be, I mean, it's not as prominent as the other one, but going towards the left side, there's probably some coin stacking there as well. Maybe not as prominent. And obviously the rectum is empty. I can't typically see the outline of the lat bowel, so I guess they're mostly collapsed. So I would think this is probably small bowel obstruction.
Good, excellent. Yeah, I mean, this is that's 100% correct. So this is small bowel, and the reason for that is, number one, the location is centrally located. Obviously, you have a loop here, which is on the right side, but most of the bowel here is centrally located. You have these complete rings here, or stack of coins, as you rightly pointed out there. They're called the valvulae conniventes, and that is a hallmark of small bowel. you tend to see them more prominently in the proximal small bowel, jejunum, and they get less and less as you go down to the ileum. And the large bowel in terms of location, typically cecum is over here where the arrow is, and it goes upwards, ascending colon, and hepatic flexure around about here. Then you get the transverse colon, extends across here, and it goes upwards towards the splenic flexure. And then you get the descending colon, which continues a sigmoid colon, and then finally is a rectum. So by location and also by the appearance in terms of the markings, we can clearly tell that this is small bowel distension with normal caliber large bowel. The only thing though is that this is a technically inadequate exam or suboptimal exam, because you can see the lower part of the scan, they haven't included the pubic symphysis. And therefore, in theory, this patient could have had an obstructed hernia, which you would have missed by not performing an exam that is low enough. But certainly in the clinical scenario, right, this is indeed suspected to be small bowel obstruction from adhesions. And that was the eventual diagnosis. The hernial orifices were clear. CT scan, again, you can make an argument for saying that even in the setting of obstruction, we find that these days, almost all these patients get a CT scan anyway. So what's the point of doing a plain film? And that is indeed a valuable argument, especially where you're trying to ration your resources. You could make an argument of going straight to CT and forgoing the plain film. And but certainly in this case, that was certainly quite useful in directing things. And the CT scan shows you again distended loops of small bowel, and you see where my arrow is here. This is just a collapsed large bowel. So this was very much in keeping with the small bowel obstruction from adhesions. Case number 14.
Dr. Chasi, do you mind if I ask a question at
yes,
this point?
sure, yeah, sure.
So it's about the slide we just, yes. So if I had this sort of patient at 10 o'clock in the night,
yep,
and I'm not concerned about bowel strangulation or anything like that, will it be reasonable to get a plain film to at least make a presumptive diagnosis if we need to start suck and drip overnight and then get a CT in the morning? Is that reasonable, or would you still think that's probably not very appropriate, rather than maybe just wait till morning and get a CT scan?
Yeah, I'm a firm believer in the fact that if you're going to get a CT scan for patients who've come acutely, who were previously well, having a normal life, and they've come to hospital, get it done now. And I don't believe in putting things off. The reason is that even if the plain film shows you distended loops of small bowel and normal caliber large bowel, and you make a presumptive diagnosis of small bowel obstruction, there are cases whereby it could be an ileus, for example, secondary to something else, which you could then because whilst we suspect it was small bowel obstruction, there are mimics of that, and we know that. So I prefer in these cases just go all the way and go for a CT scan. I mean, I agree. You got a valid point in the sense that if your patient is stable, and you're able to monitor them closely, then you could make that argument. But I said I'm firmly of the belief that if you're going to do a CT scan, do it now, and then you can relax once you know that you've got a diagnosis. There's no concerning features on the CT scan, because quite often sometimes CT throws up things you're not suspecting, either clinically or on the basis of the plain film. And that's the reason why I would go and do CT scan immediately rather than waiting, especially if you have the resources to do that.
Thank you very much. That's helpful.
Thank you. Okay, case number 14. This is a 60-year-old male who presented with abdominal pain and vomiting. And this was an X-ray done on admission. Again, that was at 2 o'clock in the morning, like most of these patients. And but yes, so anyone want to have a stab at this one here? Slightly trickier on this one here, but I hope maybe one of you guys can maybe talk your way through this.
Mommy, Spellman. You Spellman. Mommy, Spellman. Mommy, Spellman.
Are you answering? Or
Yes.
Well, you're getting your daughter to answer for you. Okay. Fade, oh, sorry, somebody was talking. Go on.
I just want to give it a shot.
Go on.
I'm not sure how much information I can get from this X-ray because I can't see the lower part of it, but
Good. So it's a technically suboptimal examination. That's a good first comment. Okay, carry on.
But the patient has got significant scoliosis, so that also makes the conclusions I'll be drawing from this imaging a bit tricky also. Obviously there is a distended, I'm not sure if that's stomach or if that's bowel right up there. It does appear there is I'm not sure if this is a pacemaker lead or an NG. But
it's a nasogastric tube. Yep. Carry on.
Oh, thank you. So she has got dilated small bowel loops. There seems to be some outlining of the it's tricky, this one. I think the patient has got small bowel obstruction. What exactly is causing it, I'm not very sure.
Okay, so what investigation would you do next? Or what would you do next? Would you do any investigation?
I would like to get a CT scan for this patient.
Okay. Anybody else have a stab at this? So we have small bowel distension and small bowel obstruction. You did mention this gas-filled structure centrally in the abdomen, and I did also point out that there is a nasogastric tube in situ. So given that, does anybody want to try and tie the findings together? This is actually a tricky X-ray abdomen, and so I'll just talk through that. So as you pointed out, this is small bowel distension. Again, you've got these complete stack of coins, valvulae conniventis, and what appears to be missing in terms of in the right side of the abdomen is you're not seeing a cecum or ascending colon, and you got loops of bowel which appear to be here over the right side here. And as I said, there's a nasogastric tube in situ. And if you look quite closely, you can actually make out a stomach up there, which is actually collapsed. And this structure here is separate to the stomach. It is massively distended gas-containing structure. It doesn't look like a sigmoid volvulus, because remember sigmoid volvulus, the coffee bean shape, which is pointing towards the left iliac fossa, whereas this is more in the upper abdomen and more centrally, just veering towards the left upper quadrant. Now the diagnosis here is a cecal volvulus. A cecal volvulus is a diagnosis you can certainly make on a plain film if you look quite closely at the pattern of the bowel distension. And as I said, if you look here, you can't actually see any cecum or ascending colon, and then you've got this massively distended gas-filled structure, which is not stomach and doesn't have the orientation of sigmoid colon. That combination of findings has to be very much compatible with cecal volvulus. In any case, in practice, what's going to happen is in almost every single hospital, this patient is going to have a CT scan of abdomen and pelvis, and that is where the diagnosis is going to be confirmed. In most cases, people are not sure when they look at the CT scan, and it's fair enough to say you think they've got obstruction, but you're not sure. As I said, invariably all these patients with bowel obstruction, unless they are recurrent attenders, will almost certainly get a CT scan to try and determine the cause, the site of the obstruction. Is it small bowel, is it large bowel, and if there's any other complications. So this was a CT scan. It doesn't actually show you the twist in the mesentery very clearly, but this structure here centrally was the distended sigmoid colon. And then here, these are the dilated loops of small bowel. So this is a cecal volvulus. So whilst plain forms are very, very useful, and you can confidently make the diagnosis, I think it's one of those that most people are probably uncomfortable about in terms of diagnosing, and CT scan would be the test that you would be more, much easier and more confidently make the diagnosis on. Again, in this case, the CT scan was performed a day later. And this is my point with these exams. If you're going to do a CT scan, do it there and then. you could make an argument that, cecal volvulus is not one of those conditions you want to manage conservatively, clearly. But I think if you're going to do a CT scan, the message for me would be do it as soon as you can. Case number 15 is a 55-year-old male who had colicky abdominal pain and vomiting. And he had been previously well up until recently. And this was his plain film of the abdomen. Yeah, again, this one's a bit tricky in terms of interpretation, but certainly in terms of technical quality, there is an element of rotation here. The patient is not straight. It is barely adequate. You can just about make out just the lower margin of the ischial tuberosity at the bottom there. And the patient has got a full bladder, which explains why there's this big soft tissue density or haziness in the lower abdomen. But what you can see on the X-ray is that the distended loops of bowel, the ones which are more central, this is going to be small bowel here. If you look quite closely, you will see the valvuli conniventis. And then the ones which are here laterally displaced, this is large bowel. You got your haustra, and again, your transverse colon heads across there. And then down here, you've got on the left flank, you've got your descending colon. But what you can notice in this patient is there's an absence of gas in the rectum. So whilst there is distension of the large bowel in the descending colon, you see that down in the pelvis, certainly in the rectum, there's an absence of bowel gas. Now, given that pattern of findings in someone with abdominal pain, he also had constipation for a couple of days. Can anybody suggest what is the likely diagnosis in this patient?
Ishmael, just before somebody answers that, just to say, there's a question for 14. When you finish 15, we'll go back to 14.
Yeah,
There's
okay,
a question on 14. I'll tell you that after this one.
Okay, yep.
Who wants to answer this before I pick somebody? Okay, Naomi, you again. Naomi.
Yes, sir. I'm not sure what the diagnosis is here, to be honest.
So Naomi, the point is that there's dissection of the small bowel and large bowel down to the distal descending colon. And then beyond that, as far as we can see on a CT scan, we're not really seeing any distended bowel beyond the distal descending. In other words, we think there's a cutoff somewhere in the distal descending colon. In a 55-year-old, the question then is, what do you think would be the most likely diagnosis?
Oh, I think it will most likely be a tumor, so maybe a sigmoid colon mass or a tumor, or in the rectum.
Good. And what exam will you do next?
A colonoscopy. Or
yes,
CT scan.
Yeah, I mean, as I said, invariably these patients in practice, they get a CT scan. And if they're presenting acutely, CT is very good at not only detecting the site of obstruction, the cause of obstruction, and also, especially where we're suspecting a tumor, it can give the information about what's happening outside of the bowel. So with this patient here, this was a patient at the time they presented, and you can see that when you compare with a plain film, so much more information you get on a CT scan. I know it's a busy looking scan, but there's a liver here in the right upper quadrant. You've got multiple low density lesions in the liver, which are metastatic deposits. And you've got fecal loading here or stasis within the distended large bowel. And the tumor itself is roughly around about here. We're not seeing it very clearly, but there was a tumor in the sigmoid colon which had metastasized to the liver. So CT gives you that ability to show not only where the level of obstruction is, but also gives you further information, which can be useful in terms of determining what to do next. Because a patient with a large bowel obstruction with a small tumor, in terms of management, the treatment considerations will be different to someone who's got a more advanced tumor and widespread metastatic disease. So it is very useful to get the CT scan done. I mean, this patient, this was a scan done 2 months before the one I showed you previously. So things have progressed fairly rapidly in a short space of time. So that was just a distal large bowel obstruction from a sigmoid colon cancer. So in that case, a plain film was useful to show us the pattern of the obstruction. But again, you know, these are patients who, as I said, I'm a big believer in CT. And as I said, if you are going to do it sooner rather than later. A lot of these patients are having abdominal X-rays. In fact, most of them in this presentation here have had a CT scan, which begs the question: why do you do plain film in the first place? Like I said, they are useful, but you know, they mustn't delay you accessing the correct test for your patient. And in this patient, I think certainly there was a short delay between the plain film and the CT, but certainly a plain film, you know, was useful to some degree. Now we'll go back, Fonso, to that. Is it number 14, right?
Yeah, number 14. The question
Okay.
is that what are the features that suggested CCOM in the plain film?
Yeah, on the plain film, that's a good question. So the first thing with the plain film is when you have a plain film of the abdomen, and one of the first things I think that's most useful is identify where the stomach is first. So go from the top. So stomach is going to be the most, you know, cranial structure, gas-containing structure you see, typically, obviously, in the left upper quadrant, heading across the midline. And if you've got a nasogastric tube, that makes your life easy, because then you can, you know, roughly trace where the outline of the stomach is. So once you've done that, if you see a large gas-containing structure, that is not the stomach. The only options remaining in that case are, it's going to be colon. So it's going to be sigmoid colon, transverse colon, or cecum. Now, in terms of this case, the clues to the fact that this was cecum were, you've got small bowel distension. If you look on the right side of the abdomen over here, you're not really appreciating your cecum. You're not seeing any haustra, because in a normal patient, you would be seeing large bowel in this location here. So it's the absence of normally sighted large bowel in this area, in the right iliac fossa and the right flank. And so by looking at it alone, you can't actually say, you know, there's nothing about it that says it's definitely cecum, apart from the fact that you can't see a normal cecum, small bowel distension, and by just going through, you know, in terms of by elimination, it doesn't look like sigmoid colon. And statistically speaking, if you see a large gas-filled viscous like that, and if it's large bowel, it's going to be a volvulus. Now, in terms of volvulus, three things really: it's sigmoid volvulus, the commonest, then cecal. The least common is transverse colon. That is extremely rare. I've probably seen it once in, you know, 15 years. So that shows that statistically speaking, you can work out what it is, but by just looking at it, it's difficult to say. You can see some haustra, and you know, in this case, which gives the clue that this is large bowel. But specifically, by just looking at it, you can't actually tell that it's cecum. It's the other clues that point the fact that this is cecum, more than just looking at this alone. But ultimately, it doesn't matter that you don't spot that it's a cecum. If you come up with saying that this patient has got bowel obstruction, the next test is without doubt, it's a CT scan, and that's going to show you the answer. So if you can actually pick the fact that there's abnormally distended bowel, that's probably good enough, because then you pick the next appropriate examination. Any more questions on that one? Okay, we take it up on case number 16. A couple more cases and then we are done. So this one here is a 65-year-old male, colic abdominal pain and vomiting, and he had a abdominal X-ray. Now this is one of those cases which frustrates me in terms of technical, where the radiographers have done the exam in two parts, which can be annoying because it makes it very difficult to try and pick out the pattern of bowel distension. And so we've cobbled together two bits of the patient's abdomen here, and then we've if we focus on this exam here on the far right side here, so you can see that they've had a right hemiarthroplasty, and as I said, it was colic abdominal pain and vomiting. Now, in this case, you can actually see the cause of this. So the patient's got small bowel distension or distended roofs of bowel, and you can see on here, for example, you've got your stack of coin appearance. So this is small bowel. If you look in the flanks, you can see some large bowel, but it's not distended. So we're thinking on the basis of that, it's probably going to be small bowel obstruction. In any case, this patient has earned a CT scan. But there are clues on the plain film as to the cause for what I believe is small bowel obstruction. Now, if you focus on this examination here, can anybody suggest what is the likely cause of small bowel obstruction in this patient?
Am I picking somebody? Mashoud Adeyemo. Mashoud Adeyemo.
Hello, I'm not
Hi.
sure, sir. Hello.
Can you have a look in the right groin area and see if is there anything there that might suggest as to what is the cause of the obstruction in this patient?
I think on the left side or over the pubic symphysis, there's some, I think there's some lucency, area of lucency there.
Yeah, this lucency, I presume this is what you're alluding to. This is the rectum here. So this is a normal appearance, okay?
Okay.
What about over this kind of area here? Is there anything you can see of this area here which might suggest what is the underlying cause?
Probably incarcerated hernia.
Yes, there is indeed a lucency here. There's a gas lucency here, which is way below the level of inguinal ligament. And this is my point about the technical adequacy of, if you are going to do an X-ray of the abdomen for suspected bowel obstruction, you need to make sure it is technically adequate, i.e. you must at the very least be able to come down to this level here. And where, the bottom of the ischial tuberosity, where you'd be able to have seen this lucency here. So this is a lucency projected below the level of the right inguinal ligament. So this patient has got a right groin hernia. Now it's difficult to tell whether it's inguinal versus femoral. Obviously, femoral commoner in women, but certainly what you can tell from here is they've got a hernia, which is probably incarcerated and is a likely cause. Again, just because they've got a hernia and they've got small bowel obstruction doesn't mean the hernia is a cause of the obstruction. So these patients will invariably get a CT scan. CT is also very good at detecting complications such as signs of strangulation or perforation, which you may not be able to tell on a plain film. So again, whilst the plain film is useful to some degree, invariably these patients are going to end up getting a CT scan of abdomen and pelvis if it is available. And again, if you are going to do it sooner rather than later. Okay. The next case number 17, is a 55-year-old female who had abdominal pain and vomiting. And she had recently been admitted with a history of right upper quadrant pain and jaundice. That was a couple of weeks ago, which had settled down. And then she's now come back into hospital with abdominal pain and vomiting. It's not the best quality X-ray, I have to say, but certainly the clues are there as to what's going on with this patient. This exam was performed erect. Now, in terms of abdominal X-rays, we don't do erect X-rays anymore. In the past, people used to do, for investigating bowel obstruction, you do an erect chest X-ray, supine X-ray abdomen, and then erect. We've dropped the erect X-ray. It doesn't really add much value, but in this case, that's what we did. You know it's erect because you can see these air fluid levels here in the bowel. Second last case or third last case, can anybody hazard as to what is the diagnosis on the basis of this X-ray?
Given the history and the findings obvious here, there is a radiopaque oval-shaped structure distally close to the midline. I would think the patient has got gallstone ileus. I would have loved to see the right upper quadrant a bit more clearly. Maybe there will be a gas in the biliary tree as well.
Good,
But,
excellent.
I think we have enough information to make a presumptive diagnosis of gastritis.
Yeah, I agree. As you've pointed out, there is indeed an opacity in the pelvis centrally. You've got distant loops of small bowel with the stack of coins, valvulae conniventis. And yeah, as I said, it's not the best quality exam, but you can see some lucency here centrally in the right upper quadrant. This is pneumobilia or gas in the bowel ducts. And so this is gallstone alias. And this patient did go on to have a CT scan, and you can see on the CT scan, there's your distended loop of small bowel, and then there's the interluminal calcified opacity with these concentric rings. This is diagnostic of a gallstone alias. What this doesn't show is the pneumobilia very well, but this is a case of a gallstone alias. Okay. Again, interestingly, despite making a confident diagnosis in the plain film, this patient did go on to have a CT scan. Okay, and we move on to the next case. This is case number 18. So case number 18 was a 55, this is a recent case that we've come across in our department, is a 55-year-old female who had a low abdominal pain and a bit of diarrhea and tendon in the left iliac fossa with raised inflammatory markers. So this was the X-ray abdomen that she had performed on admission. This was performed at 5 o'clock in the morning. Anybody spot anything abnormal in this examination? Any volunteers?
For chosen volunteers. Naomi, I know you raised your hand for the last one for somebody answered. Do you want to do this one?
That there's like maybe feces in the ascending colon on the right, but I think that the when it gets towards the transverse colon, it's not as clear.
Okay.
The bowel lumen is not as clear. I think that there's some edema of the bowel as well.
Okay.
Particularly the transverse colon, and I can't seem to make out the descending colon. But the lumen looks small to me once it gets towards the transverse colon. And then
yeah.
the edema.
Yeah, thanks for that, Naomi. This is actually a normal examination. And so it is normal to see fecal residue in the bowel like this. And I see your point about the transverse colon, but I think we thought it was actually a normal exam. There's not much gas in there, but again, you do sometimes see that there's no bowel distension, there's no free gas in the peritoneal cavity, retroperitoneum. Technically, it's not a good quality exam because it's missed out the hernial orifices at the bottom here. So it should have, a lot of these x-rays which are done these days, they just don't seem to get them right in terms of the quality of the study. So we reported this as a normal exam, and which indeed it is. You can see your psoas shadows here. This is your retroperitoneum. So sometimes if you have retroperitoneal pathology, you tend to lose your psoas shadows. You can also see your renal outline over here. And so this is the normal exam. And so we went on to do a CT scan. A CT scan was done 6 hours later because at the point of admission, it was recorded as a normal X-ray abdomen. And on the basis of that, no further action until 6-7 hours later. Now, this was a CT scan performed 6-7 hours later. The patient had obviously persistent abdominal symptoms, raised inflammatory markers, and obviously CT can be obviously a bit difficult to interpret, but can anyone have Naomi again, do you want to have another stab at this CT scan and see what you think of the pelvis there, please? Or anybody else?
Okay, who haven't I picked?
Can I give it a shot?
Okay, go for it.
Okay, so I think There are diverticulae in the sigmoid colon, a bit of outpouching standing where Dr.
Yes.
Chasi cursor
Yep.
is.
Yep.
And around it, there is some fat stranding as well.
Agreed. Anything else?
Oh yes, there are pockets of gas there.
Okay.
And maybe there is a collection as well. There is mixed. There's mixed. What's the right word to this now again? A mixed density of lesion around there. Yeah, there's obviously.
Okay. So what do you think is the diagnosis then?
So I think this patient has got localized acute diverticulitis with localized perforation.
Good, excellent. Yeah, that's exactly correct. This is diverticulitis with a local perforation. And this here is a gas-containing fluid collection. Obviously, in the pelvis, you need to make sure it's not the bladder, especially if the patient has got a bladder catheter, because you can get gas in the bladder lumen if you've been catheterized. But this was above the bladder, and you're absolutely right. There's stranding. This is diverticulitis, and there's this big collection here in the pelvis. Now, this is one of the reasons why I think plain films can result in potential concerning delays in treatment, because that plain film was completely unremarkable and was indeed reported as normal. So you've got to be careful that you don't put too much faith in what's reported as a normal X-ray of abdomen. There's a lot of pathology you can miss on an apparently normal X-ray, and from inflammatory pathology such as abscesses and neoplastic tumors, vascular ruptured aneurysms, all that can be missed on what is reported as a normal X-ray. And so if your patient is unwell and presented acutely, you've got to think seriously about performing the biggest hitter you have available. And in most instances, that means CT scan. So, it's worthwhile, doing that if you've got access to it, going for that first rather than going for abdominal X-rays. But certainly this was a big abscess in the pelvis following a diverticular perforation. Now, this patient, interestingly, was she had a high BMI, and my surgical colleagues were not very keen on getting into that pelvis and draining that, or even defunctioning. So they asked us to see what we can do for her, and this is what my colleague did in radiology. Is this is just a CT scan showing one of my new colleagues draining this collection via the gluteal muscles at the back, and we managed to insert a drain into this collection and drain that, and avoid the need for, certainly at least for now, surgical intervention. And so that was an example of the role of radiology linking with surgeons and clinical colleagues in terms of getting a diagnosis and also managing the patient as well. And the final case is a 45-year-old male who had severe abdominal pain, raised lactate, and vomiting. And again, I'll just talk you through this X-ray. Another example of an inadequate exam. So this is a big theme actually with our X-rays, is that a lot of them don't seem to be catching the hernial orifices as they should do. In this case, you can see again central dilated loops of bowel. You've got your stack of coins. This is your vulvally conniventes. So this is small bowel distension. The large bowel here, we're not really seeing it, but I think there is some large bowel over here which is not distended. So on the face of what you say, probably this patient has got a small bowel obstruction, and erect chest and at the time did not show any pneumoperitoneum. But again, because of the scenario, severe pain, this patient is going to get a CT scan, which they did. And again, even in places such as where I work, where we have CT 24 hours effectively, we quite often have this worrying delay from plain film to CT scans, and it's inexplicable as well, because if you request a CT scan and the minute your patient comes in, you can get a CT scan within reasonable short space of time. But this patient, and these are two examples of the same thing. And if I look on the transverse scan, a CT scan, you can see there's this abnormal area in the mesentery here on the right side of the abdomen. There are distended loops of small bowel. The large bowel is normal in caliber. And so this was a patient with a closed loop obstruction. Whenever you see this localized, we call it congestion or hyperemia of the mesentery like that with small bowel distension, think of a closed loop obstruction. So this is a kind of thing that you can't really pick up on a plain film. And again, this is one of the reasons why I said that even if on a plain film you've got what looks like small bowel obstruction, the thing you can't really pick up is a closed loop on a plain film, and which, as you know, is risk of perforation, ischemia, and requires more immediate surgical management than just your normal adhesive small bowel obstruction. This example here on the right is another case. Again, this increased in the haziness of the mesentery, distended loops of small bowel. This is another case of a closed loop obstruction. You've absolutely no hope of ever picking that up on a plain film. And this could be a normal plain film or an abnormal plain film. So as I said, a lot of these cases just show you that whilst you can get, a diagnosis from a plain film, things like gallstone ileus, sigmoid volvulus, maybe even cecal volvulus or colitis, in a lot of cases, even if the plain film is normal or abnormal, you still run the risk of missing very significant pathology or significant complications if you don't do the next appropriate exam, which in most cases is going to be a CT scan, apart from in very young patients where if you can try and do ultrasound scan first. So that was the cases that I had to show you this afternoon. And I've just put here just a summary of the Royal College of Radiologists in the UK, a summary of what they consider to be appropriate indications for abdominal X-ray. Now, going down the list, so number one, it says the clinical suspicion of obstruction. So I've shown you cases of small bowel obstruction and large bowel obstruction. And in fact, in all of those cases, the patients will invariably end up getting a CT scan. So there should be a caveat on number one, in the sense that I firmly believe if suspecting obstruction and the patient comes acutely, skip the abdominal X-ray, go straight to CT scan. The times when I would do an abdominal X-ray would be for your recurrent attenders, patients who've been in several times and you want to limit the dose of radiation, or maybe even your older patients, your recurrent sigmoid volvulus, such patients, it might, I think in those kind of cases, there is an argument for thinking that, okay, maybe in those cases, a plain film might be appropriate, especially when you're not really going to consider doing something else immediately. But in all other instances where you're suspecting bowel obstruction, if you have access to it, patient comes in, you assess patient clinically, the next exam should be a CT scan and not a plain film, because if it's a plain film, if it's normal, you're probably going to end up doing a CT scan anyway, especially if the patient has persistent worrying, unexplained symptoms. And if it's abnormal, you're probably again going to end up doing a CT scan anyway. So there is a role for plain films in obstruction, but you need to consider going straight to CT scan, especially if a patient is very unwell, and where you might have other diagnoses also to consider. Number two is acute exacerbation of inflammatory bowel disease. These are patients who have ulcerative colitis, maybe even Crohn's disease, or any other form of colitis, where you might be concerned about toxic megacolon or bowel perforation. In that case, it is entirely appropriate to do plain films, and quite often, sometimes it's a combination of plain films, close clinical monitoring, and serial plain films at that. So plain films every day, perhaps, to see what's happening with the status of the bowel. So in that case, I think that is an entirely appropriate exam indication. That is one case where I would say CT, I wouldn't do CT early, because quite often CT doesn't add much in those cases, because you quite often know that the patient has ulcerative colitis, and in those cases, CT doesn't really add a lot more. Number three is palpable mass. And this is one case where I think there's really no indication for plain films here. So I'm a bit at odds with the Royal College guidelines from, I think this is 2016. The first exam with a palpable mass should be ultrasound rather than abdominal X-ray. And I can't really think of any case where I'll do an abdominal X-ray first. If you see a palpable mass, it's ultrasound first, and then after that, it's going to be CT scan. And number 4 is constipation. Plain films are useful for certainly for functional studies where you're querying functional gut problems. So as part of that workup by specific specialist doctors, there is a role for plain films, when you're trying to measure the transit time through the bowel. So that one I probably have no problems with. Number 5 it says acute and chronic pancreatitis. This one are completely at odds with it. I think that one is just dated. There is no role for plain films in pancreatitis at all, 0. The exam to do is ultrasound and CT, and maybe even MRI scan as well, but certainly not plain films. Foreign body, I showed you one with the ingested battery. So yes, that one is useful because especially metallic density objects which have been ingested or inserted into body cavities, abdominal X-rays are useful at detecting that and also detecting complications. Obviously, if those foreign bodies are not radio opaque, then you might need to resort to something like CT scan. And then number 7, finally, blunt or penetrating trauma. Again, increasingly, this is becoming the role of the domain of CT scan. And so in summary, really, I said I've given you a few examples of acute abdominal cases showing utilization of plain films. In a lot of them, the abdominal X-ray did demonstrate abnormal findings, but in most cases, the patients did go on to have a CT scan. And the concern for me personally is that a lot of those cases, even in my hospital now, there's a delay from the X-ray to the CT scan. We have seen many cases where these patients have apparently normal X-rays, are sent back to the ward, and I'm not sure what medication or treatment they give them in the ward, for 2 days, and then 2 days later, then ask for a CT scan when the diagnosis could have been made on day 1. And we know that these patients lying in the hospital beds are at risk of PEs, DVT, aspiration pneumonia. So there is a risk to not to not getting these investigations early. And also, if it's a cost issue, having a patient lying on the ward for 2 days is a lot more expensive than getting the examination 2 days earlier and potentially discharging the patients 2 days earlier. So there is a cost benefit and also a morbidity mortality benefit in terms of getting these exams, the appropriate examination done first and getting it done early. So I hope that message is what I've been able to try to get across to you guys today. Thank you.
Ishmael, thank you very much for that wonderful tour de force. I think you've partly answered a question. Well, it's not a question, I think it was a comment by somebody, which obviously reflects the circumstances down in sub-Saharan Africa or low-income countries a lot, which is, I think the comment is, most of our patients can't afford CTs. Mostly we base our decision on X-rays most of the time. And so we'll be attentive to details of the X-ray. But I suppose one of the things that I take out from here is that plain X-rays, and I don't do a lot of that anymore, can be misleading. Delay having proper investigation done. And probably, and I agree with you, with your society's, what's it called, indications for plain X-ray, that the palpable mass seems bizarre, acute chronic pancreatitis and blunt abdominal injury all seem bizarre, which I'm quite surprised about. So what do you have to say to the guy who still relies on plain abdominal X-ray because patients can't afford it?
Yes, I mean, it's that's an interesting one. Obviously, I'm from Zimbabwe myself, and so we probably face the same scenario again. And but I think people have to think about this globally. As I said, the argument is that there is this insufficient resources in terms of CT per head of population. As I said, but yet these patients end up lying in hospital for days, and there is a cost incurred by nursing these patients in hospital, you know. And as I said, you've got to look at the bigger picture in terms of the cost savings from getting appropriate exams done and done early. And obviously, if clearly, if you know, in a situation whereby you've completely zero access to CT scan, then I think, you know, obviously there is some utilization of plain films. There is an argument for saying yes, you know, in those cases, plain films can provide some useful information, but the point is that not to rely on them, especially the normal. I think the one that I'm most worried about is the normal X-ray, more so than the abnormal X-ray, and it is not to put your faith too much in an apparently normal X-ray, because I think if you've got bowel distension and you've got bowel obstruction, everybody would be like, you know, pretty much clear of the fact that maybe let's refer the patient on to the next big hospital in the region, which might have a surgeon, or would, and in some cases, people will be happy to operate on the basis of the clinical scenario and the X-ray. But it's the ones with the apparently normal exam, which I would caution you to be careful about those patients, especially where you have hard clinical symptoms, because I think those are ones where we find quite often we have the significant pathology, your ureteric calculi, your pancreatitis, your gallstones, your bowel pathology, and things which are of potentially, significant harm to the patient they've not addressed. So as I said, I think the normal X-ray, if you are doing X-rays, as a first, because you've got no access to it, just be careful of dismissing the normal X-ray. I think go more on your clinical judgment and clinical findings, more so than the normal X-ray. I mean, it is useful, I have to say, especially in younger patients. It certainly can be used, but as the patients get older, there's a lot more pathologies come into play, and therefore the reliance on the abdominal X-ray becomes a bit more. It becomes more, unreliable to certainly bank on the apparently normal X-ray.
Okay, I just first of all, before we go on, can you please, all of you, can you just fill your feedback forms, please, before you leave? Any questions from the floor?
I've got one, please. Is that all right?
Go on.
I must say thank you to Dr. Chasi for this very educating session.
That's okay.
I've had the privilege of having radiology trainees put us through how to interpret some of these things, but this is absolutely above and beyond. Thank you.
Thank you. Thank you.
One question, okay, maybe two questions. I think I'll need Mr. Adedeji's input on this as well, being a colorectal surgeon. If you've got a patient who's known to have UC and has come with what looks like toxic megacolon, and plain abdominal film is giving features highly suggestive of toxic megacolon, and you think the patient is going towards needing surgery, would you be comfortable operating just with the evidence you've got on plain film, or would you want to get a CT scan? You probably characterize how extensive you would, maybe to just plan how extensive you need to resect and things like that. And to Dr. Chasi, would you think it's an appropriate request if one made such request for a CT scan for a patient who is known to have UC and has got a plain film that has almost all the classical features of toxic megacolon? And the second question is,
should you do the first question first, and then you can ask the second question?
Okay, thank you. That's
okay.
fine.
I'll go first, and then let Dr. Chasi tell me I'm terrible. Now, for toxic megacolon, there are two scenarios. If the patient comes in with dilated bowel, so it's admitted with dilated bowel, and we know they've got ulcerative colitis, I would be happy to treat them as emergency, but they have only 24 hours of treatment before I take them to theater if they're not settling, because I don't know how long it's been there for. But like the picture that Dr. Chasi showed, if they've come in and there's no dilatation on the bowel when they come in, and we're treating them and they become toxic while we're treating them, then yes, I'll take them to theater once the X-ray shows that they've got toxic megacolon without a CT scan. So I think that in this case, and I think Dr. Chasi might say, I love CT scans But in this scenario, on both cases, I'm happy with a plain X-ray to take them to theatre. And depends obviously on the clinical setting, but they don't particularly need, they don't need any other thing, because what we're worried about is a perforated. And if we look at it, is that if you take an acute colitic to theatre without perforation, and that's without toxic megacolon, the mortality rate, because they tend to be very young, you take them to theatre without any perforation and all of the mortality rate is less than 1%. They would survive. But if they have toxic megacolon and they perforate, the mortality rate is 1 in 3. And I think this is one of the cases that I'll do without CT scan. Ishmael.
Yeah, I mean, we do sometimes get asked to scan these patients, and the question quite often, I mean, I've made a good attempt at resisting these over the years. The question we sometimes get is it a micro perforation? Because clearly these patients have done an erect chest X-ray showing no perforation, or indeed the abdominal X-ray showing no perforation. And invariably, probably maybe a couple of times in the last, I don't know, maybe 10 years have I seen on the micro perforation. So I think in these kind of cases, I would say, you know, I don't think there's a major role for CT here. And I'd always pose a question to the surgeon, what question do you want answered? And because we know that the patient has got a pancolitis or diffuse colitis, from the plain film, you kind of have a good idea of how extensive it is. And also, if clinically and radiologically we think it's toxic megacolon, there's no added value to CT. The only thing is there perforation or micro perforation, but is that going to make it? Answering that question is not necessarily going to stop them surgeons operating. So if the question for me is always, is this exam going to change management? And if the answer is no, then you know, then clearly for me it is highly unlikely to be the appropriate exam. So that's what tends to guide me in terms of determining what is the next most appropriate test to do.
Your second question?
Thank you very much. So the second question, please oblige my quest for shortcuts. Most of us have acronyms of how to approach interpreting chest radiographs. Most people use ABCDE or out to in approach and things like that, just to get a quick summary of what exactly is happening to the patient looking at the chest image. Is there anything you could suggest to us that we could, any approach we could use to look at plain abdominal films in a way that is systematic and we can take note of most important things? Thank you.
Yeah, that's a good question. That one is, and embarrassingly, I have to admit one that I've not really thought about. And I guess when you've been doing this for many years, you end up just almost doing it as an automatic mode. But I suppose the one way of looking at it is to break it down into, you know, what's in the abdomen and pelvis. You got your whole of viscera, which is what we targeted today. So you almost want to take yourself through a journey through from the stomach to the rectum, and try and point out those structures. As I said, start in the upper quadrant. You know, where is the stomach, and you know, you tick that off consciously. And then where's the small bowel? You take that off, and then where's the large bowel? And in terms of location, obviously stomach is left upper quadrant, you know, crossing the midline. Then the small bowel just centrally located. Large bowel, have a mental picture of where the large bowel is located, i.e. from the right iliac fossa up the right flank, you know, hepatic flexure, and then transverse colon, down on the left side, splenic flexure, and then sigmoid colon. And so you've assessed the whole of viscera in terms of distension, wall thickness, and the location. And then after that, obviously, straight after that, I would look for abnormal gas distribution. Now, on an abnormal X-ray, abnormal gas distribution, i.e. extraluminal gas, you're talking about pneumoperitoneum, for example. That's what's called regular sign. So you can tell from that if the patient has a pneumoperitoneum, and also retroperitoneal gas. So those are the things I would look for straight after having assessed the whole of viscera. Is, are there any other abnormal locations for gas? So pneumoperitoneum, retroperitoneal gas, pneumobilia, portal vein gas. And then after that, I'll then go and assess my solid abdominal viscera. Again, you should have a mental picture of where things lie, i.e. liver lies in the right upper quadrant, spleen in the left upper quadrant. Roughly assess where the kidneys are, the psoas shadows, and the outline of the soft tissues in the pelvis. And then after that, I'll certainly do the bones, and so that and finally the lung bases as well. So that will be my sort of, you know, basic advice. But certainly, if you have a mnemonic that you use, by all means, you know, whatever you use, as long as you use it consistently, that's always the key. Use it all the time. Don't take shortcuts. What you find is the problem a lot of the times is that people see obvious pathology, then your eyes get distracted and get drawn to that. Then your mnemonic or your shortcode thing goes out the window. What you almost want to do mentally is register that there's pathology there, but just get out of your mind and just go through your normal routine and then come back to the pathology. And in most cases, you'll find they have a better, more complete picture that way, rather than just focusing on just what's abnormal.
Thank you very much.
Okay.
Okay, any more questions? I think we've taken Dr. Chasi's time a lot this evening. Okay, no more questions. Ishmael.
Yes.
Thank you very much for your time.
No problem. You're welcome. You're welcome.
Thank you very much. It was great.
It's been a pleasure. Thank you. Thank you. Thank you. Thank you.
And everybody, please, your feedback forms, please, please, please. And I would also text Fumi at some point. We're in Nigeria first week in November. So if you guys want to meet up, let me know. We can arrange something on the 9th of November. Okay, thank you all.
Thank you. Thank you, guys. Thank you. Cheers. Bye-bye. Thank you.
Ishmael, thank you.
Cheers. Thank you. Bye. Thank you.
Thank you.
Cheers, one,